All right, so morning everyone. For those of you who don't know me, my name is Kendrick. I'm in the final stages of completing my PhD in medical physics, but I'm also an academic of UWA as well. So I just started teaching at UWA full time. Specifically, I'm doing some lecturing and research in both physics and computer science as well. And today I'm going to be talking about two papers that were published as part of my PhD project. And these papers are focused specifically on response assessment using PSMA PET-CT scans. So first of all, we'll talk about the first paper. And this paper is the validation of the RECIP 1.0 criteria using AI-based and manual delineations. We'll start off with an introduction, but I won't spend too much time on this before we get straight into the methods and the results. So prostate cancer, I'm sure most of you are aware, very significant problem in the world associated with significant patient mortality and morbidity. It's also cancer with the highest incidence in males, looking at about 20,000 cases diagnosed annually. In terms of patient outcomes, if the disease is detected at early stages, we typically have quite high 5-year survival rates, around about 90%. But once the disease metastasizes or spreads to other parts of the patient's body, we see its lethality increasing very dramatically. So we see those 5-year survival rates dropping. And in the case of bone metastases, which are one of the most common sites of metastatic spread for prostate cancer, we see them dropping even further to around 10%. So clearly it's a pernicious disease. Now, medical images play a really important role in managing metastatic prostate cancer, whether that be diagnosing the presence of lesions throughout the patient's body, offering a prognostic assessment of how the disease is likely to progress in the future. And one thing that's going to be the particular focus of this talk today is the assessment of treatment response. And in this space, gallium PSMA PET imaging is really becoming the standard imaging modality because it binds, or this specific radiotracer binds with very high affinity to the PSMA receptor, which is overexpressed in the overwhelming majority of prostate cancer cells. But of course, medical images, on top of being something that we can just sort of qualitatively interpret, are actually a form of quantitative data. And we can analyze this data in certain ways to yield improved patient outcomes and also optimization of clinical workflows. And we're talking a little bit about exactly what that means throughout this presentation. Now, one of the key ways that we can analyze medical images is by ascertaining the total tumor burden from those images, right? So understanding what is the patient's tumor burden, and let's say, for example, we have PSMA PET at baseline, PSMA PET at follow-up, approximately 6 months later, say, and we want to assess what the change in the total tumor burden is between those two scans. This is an important way to assess whether a patient's responding to treatments or not, especially in metastatic disease, when disease can be very high volume. Now, of course, there's many different ways that we could measure this from those images. So one way might be that we have a nuclear medicine physician manually go through the scan, determine the sites of metastatic disease, and we use that to quantify the tumor burden change between those scans. Now, of course, that's highly subjective, subject to inter-observer variability, and as well as very time-consuming. So the other way that we can do this is we can use advanced quantitative methods like convolutional neural networks, AI methods, to automatically segment disease from these two scans, and we can use that to determine the change in tumor volumes between the two. So the aim of this first paper that I'm going to go through was we wanted to validate the prognostic utility of a specific response assessment framework, RECIP 1.0, and I'll get into exactly what that means in a couple of slides, in our biochemically recurrent prostate cancer cohort. The second aim is we wanted to determine whether we can perform the classification automatically using AI-based delineations. Okay, so the patient cohort, we had access to 199 patients with baseline and follow-up scans. They were biochemically recurrent prostate cancer patients. So biochemical recurrence defined as one of either of those two things following definitive primary treatment for the primary lesion, so radical prostatectomy or radiotherapy. Median of 6 months between the two scans, baseline and follow-up scans, and patients were either negative or oligometastatic on conventional staging imaging. So we're talking about bone scintigraphy and abdomen and pelvic CT scans. So this is a particularly low disease burden metastatic prostate cancer cohort, which is important because this particular response assessment framework had only been validated in very high disease burden patients, specifically castration resistance, which you just heard about previously. So we followed these patients up from the time of their second scan to facilitate the survival analysis we wanted to conduct. And in the interim period between their baseline and follow-up scans, they received standard of care treatments. So this can include surveillance of the disease, so no treatment but actively surveilling it, androgen deprivation therapy, radiotherapy, or chemotherapy. As I said before, so we analysed gallium PSMA PET-CT scans, so we didn't use any fluorine-based traces in this analysis. This is something we'd like to do in the future. And this is just a little bit of information about how we actually acquired those scans. So we acquired the scans after the IV administration, 2 megabecquerels per kilogram of the radio tracer. It was a combined PET-CT scan as well. And we had patients from 2 different imaging centres, so the majority of them were from here, and about 23 were from Fiona Stanley Hospital. So how did we perform the progression assessment? So as I said, we used the RECIP framework. And the RECIP framework is encapsulated in this image here. So what the RECIP framework says is if the patient has a PSMA volume increase of greater than 20% between their baseline and follow-up scan and the presence of new lesions, then they're classified as having progressive disease. So why did we choose this particular framework? Well, first of all, recent studies have suggested that they had the best prognostic utility out of the available frameworks that could be used to assess response between 2 images. So we're talking here about RECIST 1.1 criteria, also PERSIST criteria, which would be standard for interpretation of PET images. The second reason we chose this was because no studies had undertaken a validation of this criteria in a biochemically recurrent disease prostate cancer cohort. So as I said, this particular framework had been validated only in very extensive disease metastatic prostate cancer patients. We didn't know whether it could be used at a more early stage of the disease. And finally, no studies at all, regardless of whether they were undertaken in high or low volume disease patients, had validated whether we could use AI-based delineations to actually perform this response assessment and what the prognostic value of that was likely to be. So in this particular study, we performed the progression assessment in 2 different ways. First of all, we had an expert nuclear medicine physician go through the scans and undertake a semi-automated delineation methodology. This began with a 3 SUV body weight threshold, and then following that, there was manual removal of physiologic uptake and inclusion of missed pathologic uptake into those segmentations. And they were interpreted according to a standard criteria for interpreting these images, the PSMA framework. Now, in a subset of these patients, 74, we used AI-based delineations to determine the tumour volume for both baseline and follow-up scans. This particular trained artificial intelligence model was one of the other papers I published as part of my PhD, and it was actually trained on the remainder of the patients, which is why we only tested this in a subset of the patients. So these 74 patients were the testing set, essentially, that the model was never exposed to during the training process.
Hello, that PowerPoint is not changing for the people online. Are you guys using that?
Yeah, okay.
Maybe you're sharing the wrong screen, potentially. I don't know. It's just stuck on the first page.
See what they're seeing is that one.
I'll stop sharing and I'll just share it again. If I was sharing the PowerPoint directly. So can you see that now?
We can see the results expert physician.
And now if I make it into this.
Yeah, that's better. I think so. Yeah, perfect.
Yeah, okay.
Thanks.
Reading as I go forward. I just want to check.
No, that should work because you see the red marking around your
okay,
that means you're sharing that.
Yeah, okay.
Yeah, that's working now. Thank you.
Cool. Yeah, all good. So we'll go through some of the results that we found looking at this particular response assessment framework. So of the 199 patients who received the manual delineations, 47 of them presented with a tumour burden increase of greater than 20%. And what you can see is that if we conduct a standard Kaplan-Meier analysis on this and look at the hazard ratios, this is associated with significant reduction in survival probability for those patients. Now, of those 47 who did present with that greater than 20% tumour burden increase, 26 of them also presented with new lesions between baseline and follow-up, which means they would have met the criteria for being RECIST progressive. And you can see here, again, it's kind of being blocked a little bit, but I'm sure you can see it. This is associated also with a significant reduction in survival probability for those patients. So we can see, actually, according to the manual observer delineations, this particular framework is highly prognostic for patient survival. Now we'll look at the same thing, except in this instance, we'll look at the AI-based delineation. So as I said, in this case, we purely used the AI framework to determine the change in tumour volume between the two images, and then we interpreted the AI-based delineations to see if there was new lesions detected by the AI model between the two images. Of the 74 patients who received those AI delineations, 20 had a tumour volume increase of greater than 20%. And again, you can see the hazard ratio is 3.65, and it's a statistically significant increased risk of death for those patients.
Can I check, is this subgroup does it matter if they have METs? Does it look into that as well, or just a change in?
So no, it's just the change.
Yeah.
So for example, if a patient had 0 tumour burden in the baseline scan, and then they had a lesion in the follow-up scan, that would be recent progressive as well. Yeah. And then we can look at, of those 20 patients, how many of them also had AI-detected new disease sites between the two scans. And we can see, again, this is associated with a significant risk, a statistically significant reduction in survival probability for those patients. So what this shows is that it's robust to 2 different frameworks, essentially. We could use manual observer delineations according to the RECIP framework, and we can also use AI-based delineations in order to make this classification for the patients to determine if they're responding or progressing to disease, to treatment, sorry. So we can also look at the concordance between the 2 methods, right? So of course we had 2 different methods of assessing the change in tumour volume between the scans. In 84% of cases, the AI model agreed with the nuclear medicine physician. This actually resulted, interestingly enough, in a Collins kappa of 0.31. So for those of you who aren't aware of what that is, it's a statistical metric that's used to assess agreement between 2 different methods. And 0.31 indicates what's referred to as fair agreement. But the reason there's such a large discrepancy in this particular case, so we had 84% agreement overall, but a Collins kappa statistic of 0.31, is because of what's referred to as the kappa paradox. This is sort of in-depth statistical stuff, but basically the long and the short of it is, if you have 2 groups which had a very large difference in prevalence, so in this particular case, we had a lot more patients with RECIP non-progressive disease than with progressive disease, then you can run into what's called the kappa paradox, where you don't have a high agreement, even though you have 84% overall agreement between the cases, if that makes a bit of sense. Okay, so there was also a very high correlation between the tumour volumes as measured by the manual observer and also the AI model as well. So we have very high spearman correlations here. And this particular case here is just demonstrating one of the failure cases. Unfortunately, you can't see the false negative of the AI model, so just quickly move that out of the way. But basically what this is trying to demonstrate here is that this AI model actually missed a nodal metastases above the diaphragm. And that caused, for this particular patient, where the observer classified it as progressive disease, the AI model didn't classify it as progressive disease because it missed this lesion here. And we suspect the reason for this is because this didn't have a very high SUV max, it was less than 3, about 2.8 or something. So briefly just summarise the results of this first paper here. So the RECIP framework for assessing progression is highly prognostic, and it is prognostic with both of these segmentation methods. So we can have a nuclear medicine physician go through the scan, delineate the lesions. As I said, very time-consuming process, takes a lot of time to do this, and it scales with the patient's tumour burden. So the more lesions they have, the more time it's going to take for them to delineate them. And this adds really important evidence. So there was a recently published framework called the PROMISE V2 framework. Again, I'm not sure if any of you are familiar with this, but basically it's a standard framework for interpreting PSMA images. And what it actually said was that RECIP was one of the criteria that should be used for assessing response for prostate cancer patients with PSMA images. Now, I won't go too in-depth into the details, but basically this was based on a very limited number of studies. And as I said, there had been no validation of it in biochemically recurrent prostate cancer patients. So we're adding important evidence suggesting that this framework can be used at this stage of disease, and it is robust to 2 different segmentation methods. Now, of course, some limitations with the study. We administered heterogeneous treatments between the 2 scans. This was just a peculiarity of the particular study we acquired the data from. While this is reflective of the actual clinical scenario, so there's obviously a variety of different treatments you can administer prostate cancer patients at this stage of disease, it does make it difficult to make robust conclusions about specific treatment modalities, so androgen deprivation therapy, for example, or chemotherapy themselves. So we'd like to further validate this in more standardized treatment patient cohorts as well. As I said, the AI framework was not completely automated, so while we did use the AI delineations exclusively to determine the presence of new lesions, we did still have to check if there was new lesions between those two scans. So one clear pathway of future work here would be we can use advanced registration algorithms to match the baseline and the follow-up images to each other, and then we can automatically determine if there's new lesions or not between those two scans rather than having to manually check ourselves. So that would be something that we'll be looking at doing in the very near future. And critical thing, in my view, is that intra-observer variability wasn't analysed in this. So we really want to put this in the context of intra-observer variability. If we have two different nuclear medicine physicians, what are the differences in RECIST progressive and RECIST non-progressive classifications that they're going to make? And if the AI model falls within that sort of variability range, then it's essentially no different from just using a different observer. And also, what's going to lead into the second part of the talk is that we've been discussing predominantly at this stage patient-level biomarkers, so tumour burden as measured from the whole patient scan. But of course, if we're taking a sort of patient-level approach, this might obscure potential heterogeneity at the lesion level, right? And of course, in metastatic cancers, patients may have multiple different disease sites. So that's going to lead quite nicely into the second paper that I'm going to be
Just before we go to the second paper, can I just check the methodology of the first paper?
Yeah.
I might have missed it, but what's the interval between the scans and what's the selection criteria? Because you just mentioned biochemical failure. I find it quite unusual that people have so many mets, they just have a low biochemical failure post-RADS.
Yeah, so there was actually a quite low median number of lesions per patient. So we're talking about a median of 2 per patient. That picture that I was showing you in the previous slide, that's actually from the RECIST paper itself. So that, as I said, that was in a much more advanced disease patient cohort. So in our cohort, we're looking at a median of 2 per patient.
And what's the gap of the scans?
6 months time period.
They're all 6 months.
Median of 6 months, yeah.
Baseline and progression.
Yeah. So that's a good point. It really does only apply these conclusions to that 6 month time period. And we'd also like to know, well, what is the time period where you couldn't use this anymore and wouldn't be prognostic for the overall survival?
And did any patient have change in their management during that 6 time, or did they none of them start ADT?
Good question. I'm not sure about
because
that.
you're just wondering whether intervention like stereotactic body radiotherapy to oligomet, or well, they probably wouldn't have known about oligomet, but starting hormone, different types of hormones, intervention may change it too.
Yeah, that's definitely possible. Yeah, you're right. So as I said, we would like to have a much more standardized treatment cohort as well when we're validating this in future studies. Okay, cool. So we'll move on to the second paper. So this second paper, as I said, is taking a bit more of a lesion-based approach to doing this, rather than taking that more patient-level approach that we took in the previous study. And here we're talking about, the title of this one is the Quantitative Biomarkers for the Analysis of Lesion-Level Progression in Prostate Cancer. So, as I mentioned, summary assessments of patient progression at the sort of whole patient level can potentially obscure heterogeneity at the lesion level, right? And what I mean by that is that you might see a patient progressing in terms of total tumour volume, but individual disease sites might actually be responding or stable in that scenario. This is something we wanted to look at a little bit deeper. Now, of course, there's many different frameworks that we can use to assess that sort of patient-level progression. We've got the RECIST, standard criteria for response assessment in solid tumours, PERSIST, which would be used as the criteria for interpretation of PET images, of molecular imaging modalities. And then we've got the PSMA-specific ones. These were designed specifically for interpretation of PSMA PET images. That's the RECIST and the PSMA PET progression criteria. But the problem when it comes to lesion-level progression is that there's a number of different ways we could potentially make that measurement, right? So if you can imagine that we're looking at a lesion in a patient, how are we actually going to assess whether that lesion is progressing, stable, or responding just purely based on radiographic information, right? Because we can't solid biopsy every metastatic tumour in these patients. So would we, for example, take the mean uptake of that tumour and analyse the change in that between baseline and follow-up. That's a potential option. We could also look at the change in the volume, the change in the SUV max, so what's the maximum uptake in that tumour area, or the peaks. The SUV peak is another standardly used metric in interpretation of PET images. And then the second question you might ask is, well, what response assessment threshold do we actually use to make this classification, right? So is it, if the SUV mean changes by more than 20% between baseline and follow-up, then we start classifying it as a progressing lesion, or is it plus or minus 30% or plus or minus 40%? So there's a number of different ways we can make this measurement. And depending on how we make this measurement, the patient may have different progression patterns, right? So in this sort of very simplified scenario here, we might have the case where both of these lesions are not progressing, so we have a patient with no progression. We might have the example of a mixed progression scenario where one lesion is responding and one lesion is getting worse or progressing, or we might have a systemic progression scenario where both lesions are getting worse in this particular patient. So really our aims of this study were to analyse the lesion level patterns of progression in our particular BCR cohort, and then we wanted to sort of package these lesion level classifications into a patient level summary and assess the correlations between those and overall survival as well. We wanted to sort of make an estimation of what the best metric would be to use when you're assessing lesion level progression. So this is the same cohort from the previous study. We had 199 patients, baseline follow-up PSMA scans. Because this was a matched lesion analysis, we implemented some exclusion criteria as well to this. So 42 patients did not have measurable disease at baseline, so we excluded those from the analysis because that means we wouldn't have any lesions to match between baseline and follow-up. 19 patients had follow-up imaging less than 5 months or greater than 7 months from their baseline scan. So basically our intention here was to standardise as much as possible the time period between baseline and follow-up scan. And this left us with 138 patients with PSMA at baseline and PSMA PET-CT 6 months later, essentially assessing progression. And what we did is the same nuclear medicine physician from the previous study delineated all the lesions between baseline and follow-up scan. It was an incredibly arduous task, it took him a lot of time. And this enabled us to actually extract biomarkers at the individual lesion level, right? So we're able to extract the change in SUV mean, for example, for each lesion, change in SUV peak, maximum, and also volume. And what we did is we applied 3 different response assessment thresholds, so plus or minus 20, 30, or 40%, and used that to actually classify each individual lesion as progressing, stable, or responding.
How did you come up with those numbers, those cutoffs?
So those cutoffs are basically where the range of repeatability falls for most of these studies. So if you look at the repeatability measurements, for example, for SUV mean, it falls anywhere between sort of 20% to 40% depending on the study. And that repeatability range defines, in a test-retest analysis, how much percentage change is actually required before you can say, yes, that's a true change in the lesion, rather than just sort of variation in the instrument.
So there's this background data supporting that, those figures.
Okay, so in total, we had 536 lesions at baseline. As I said, median of 2 lesions per patient, range between 1 and 34. That was actually one outlier there. 208 lesions were not identified at follow-up scan, which means they were complete responders. They completely responded, which is good. And then we quantified the biomarker difference. So for each of those different biomarkers, for the remaining 328 matched lesions. And you can see here we've just plotted the percentage tumour response according to all of those biomarkers. One thing I'll just note is that this plot on the left here is regarding the different SUV peak measurements. So for those of you who aren't familiar, SUV peak has a number of different definitions, and it's not really standardized what sort of definition is used in the literature. And it depends on 2 things, essentially. The first thing is the radius of the sphere. So the SUV peak is a spherical volume placed in the lesion. So it depends on that, and also where exactly that sphere is placed in the lesion. So basically, it can be placed on the maximum uptake area, so the SUV max, or it can be iterated over the volume to determine where the highest uptake area is. So we just implemented all of those different definitions. Now, one thing I wanted to look at was, okay, we've got these different biomarkers that we can use to measure radiographic response, the stability or progression at the lesion level. What is the actual discordance in those, right? So, for example, if you choose volume to make your classification of the individual lesions, as opposed to choosing SUV mean, does that give you a different classification, right? And the answer to that question is overwhelmingly yes. So dependent on the imaging biomarker that you choose, there was 60% of lesions that had a discordant classification. So basically, purely just by changing the imaging biomarker that you're using to assess response, it can change how you're actually interpreting the response, stability, or progression of the lesion. So this, of course, has important clinical implications, right? Purely based on your chosen biomarker, it can actually impact how you're interpreting the response of that lesion. And this was the case regardless of the response assessment threshold that we chose. So plus or minus 20%, 30%, or 40%, you can see that in all cases, it was about 62% of lesions that had a discordant classification based on this. Now, we decided to just exclude volume and only look at the SUV-based measurements in exactly the same analysis I was just describing. In this case, we can see that the discordance actually drops quite drastically. So it drops to between 23 to 26%, which is still substantial. You know, if you think about a clinical practice scenario where 23% of your lesions could potentially be classified differently if you just choose a different biomarker. But this indicates that volume contributes quite substantially, the volume metric, to the observed classification heterogeneity at the lesion level. And here's just an example of what I'm describing right here. So this was a particular lesion, and we're looking at 3 different biomarkers here. And you can see that based on which biomarker you choose, so SUV mean, volume, or SUV peak, it can be classified simultaneously as progressing, responding, and stable. So we need a lot more research into this to understand what the best metric actually is in terms of assessing response at the lesion level in this fashion. So where does this leave us? We have substantial lesion level classification heterogeneity, right? Depending on the imaging biomarker that you choose to analyze response at the lesion level. And this obviously sort of brings forth an important question. Well, what metric should we actually use? Now, in my view, this is a very complicated question that depends on lots and lots of different factors. So this study doesn't attempt to definitively address this question by any stretch. But it does attempt to make a step towards answering this question. Some of the factors I think that will be important is how easy is the biomarker to use in clinical practice. So as an example, SUV max is simply the maximum voxel in that lesion area. You do not need a contour of the whole lesion in order to calculate that, right? So that's much easier to implement in clinical practice than say the SUV mean, where you do need a contour of that particular lesion in order to calculate the mean uptake in that area. Obviously, one other important factor, which is the subject of this study, is relationship to relevant clinical endpoints, so overall survival, right? So if you use these lesion level progression classifications, put them into a patient level summary and assess the relationship with overall survival, obviously you'd want the one that's most prognostic, or at least that's going to be a factor in determining which biomarker you want to use. As I was just mentioning before, repeatability is also important. What percentage change is required in these biomarkers before you can actually say, yes, there is a change in the tumour and it's not just variability in the instruments. And reproducibility is also a really important one as well. So how reproducible is the biomarker between different operators, right? So again, the SUV max and SUV mean example is a good one because SUV max is significantly more reproducible than SUV mean, right? And that makes sense. If you're just trying to find the maximum voxel in an identified lesion, that's a lot easier to do between 2 different operators than getting the contour exactly accurate or exactly the same between those 2 different operators. And of course, if you don't get it the same, you're going to have a different mean uptake value. So this leads us to the second part of this particular study, where of course we extracted the biomarkers, the change in them between lesions, between baseline and follow-up scanning. We have our classification, so is each lesion progressing, is it stable, is it responding based on those classifications. But we then decided to implement a much more lesion-based approach to determining patient-level progression. And specifically, we implemented the criteria developed by Osorio and colleagues for metastatic cancer. It wasn't developed originally for prostate cancer, but as we'll see, it does have direct relevance to prostate cancer. So this is the particular criteria here. What we did is we classified patients as having systemic progression, mixed progression, or no progression. And here is the classifications. I probably won't go through the whole table, but as an example, if a patient had less than or equal to 3 lesions at baseline, and they had 1 lesion with progressive disease, and this includes the presence of new lesions between baseline and follow-up, so a new lesion would be classified as having a progressive disease, then they have mixed progression. Or if they have greater than or equal to 2, it'll be systemic progression. Now, I should point out, we don't know that this is the best way of doing this. The point that we sort of set out to do as we started this study was, well, we want to set the criteria that we want to use before we start looking at the data, because we didn't want to bias the results for our particular data set. Right, so this is why we chose this framework. As I said, it wasn't actually even developed for metastatic prostate cancer, but as we'll see, it does have direct relevance to it. So we can look at some of the results. We followed the patients up again from the time of their follow-up scan to facilitate the survival analysis. I'm okay for time.
Yeah.
Yeah. And we can look here at the hazard ratios and 95% confidence intervals for all of these biomarkers between patients with systemic and no progression. What we can see is that for all the investigated biomarkers, so regardless of the one that we chose, when we use those lesion level classifications and put them into a patient level summary according to those criteria, systemic progressors had a significantly higher risk of death relative to patients with no progression. But of course, we're doing a lot of testing here. So we're doing all of these biomarkers for 3 different response assessment thresholds. So we applied the Bonferroni correction as well to correct for multiple testing. So basically, for those of you who aren't aware, again, this is a statistical method of correcting for the fact that you're testing multiple different things on the same data set. And just by virtue of chance, because you're doing that so many times, you may find a statistically significant result that isn't in fact correct. So we applied the Bonferroni correction, and what we found actually was that still all of these different biomarkers had a statistically significant reduction in survival probability for systemic progressors, with the exception of tumour volume. So again, tumour volume seems to not be the best metric to use when assessing response at the lesion level based on these results. Another thing that we found was that SUV mean consistently, regardless of the response assessment threshold that we used, demonstrated the highest C index, which is just a measure of how well your regression model fits to the data. And that was regardless of the response assessment threshold. And the plus or minus 30% actually performed the best with the highest C index and hazard ratio. So this provides some evidence that SUV mean might be the best metric to use when you're assessing lesion level progression and putting them into these sort of patient level summaries here. As I said, it is a very complicated question, depends on a number of other different factors, not the least of which how difficult it is to actually generate these segmentations in the first place. We can look at the SUV mean results in a lot more detail here. So we can see that we had 85 patients. This is looking at the SUV mean at the 30% threshold. 85 patients had no progression, according to this. 29 patients had mixed progression, and 24 patients had systemic progression. And I've just generated Kaplan-Meier plots comparing all 3 of those groups here. Some of the salient conclusions are that systemic progression is associated with a significant reduction in survival probability relative to both no progression and mixed progression patients. So what this tells us is that if you're using the SUV mean to measure this, patients with systemic progression at this stage of disease, and as measured by the SUV mean, is a very, very important prognostic factor for patient survival, and these patients should be considered as quite high risk. What we also found is that mixed progression patients did have worse survival outcomes relative to those with no progression. However, you can see on the plot, this actually just marginally doesn't reach the level of statistical significance. So it's important to note it's not statistically significant, but you can see the survival plots start to diverge towards the end of the time period. We also looked at baseline predictors of progression. So, for example, we plotted the baseline tumour volume here for each of the 3 categories and PSA levels at their baseline scans. against the three categories as well. What we found is that patients with systemic progression did have a statistically higher baseline tumour volume, and this very, very just reached the level of statistical significance. We're talking quite marginal here. So they had a median of 4.7 mils versus 1.69 mils. So this indicates that perhaps a high baseline tumour volume might be an indicator of future progression. But based on how marginal this result is, I wouldn't put too much stock in that particular result. This is not the case for PSA levels at baseline. So the three groups did not have statistically different PSA levels at baseline. Okay, so we'll talk a little bit about intra-patient heterogeneity, and we're coming towards the end here, so we'll leave some time for questions. So intra-patient heterogeneity, so response within patients with multiple disease sites, was found to be quite common. So, for example, 60% of patients with multiple disease sites exhibited a mixture of stable, progressing, and responding lesions. Okay, so within the same patient, very common to have scenarios where lesions are responding differently. Still, if we subgrouped for the patients that only receive systemic therapy, so for example, androgen deprivation therapy, we still found that around 44% of those patients, even though they were receiving systemic therapy, had heterogeneity in response between lesions within the patient. So this adds, I think, evidence suggesting there is underlying biological heterogeneity between disease sites, and it confirms a number of other studies that have sort of suggested the same thing. Now, I would just like to note a special case of the progression categories that we've mentioned here. So if we combine the systemic and mixed progression categories, I did say this was directly related to metastatic prostate cancer. If we combine those two categories, what we actually find is that criteria, or if we combine them into a single category called progressive disease, for example, this becomes equivalent to the PPP criteria that I mentioned at the start of the talk. So that was one of the other specific PSMA criteria for interpretation of PSMA images. And specifically, this becomes equivalent to how that criteria was elucidated in a recent consensus statement of nuclear medicine physicians and radiologists. So what we did is we combined those two categories, and we decided to also investigate, well, is this framework also prognostic for patient overall survival? And the answer is very clearly yes, that is still prognostic for patient overall survival. So we conducted this for 3 different biomarkers, the ones that we thought would be the most likely to be implemented in clinical practice. It's the SUV mean, SUV max, and the SUV peak. And here we're talking about the particular SUV peak measurement that's recommended by the PERSIST criteria. I'm aware that I'm saying a lot of acronyms, so if you're not following along, please just let me know, and I can hopefully try and explain it. But basically what we found is that regardless of the metric that we chose here, this PPP criteria is prognostic for patient survival. And again, SUV mean actually demonstrated the highest prognostic value as measured by the C index. So we have multiple different frameworks that we can use to assess progression at this stage of disease. We've got the PPP criteria here. We've got the interpretation of systemic, mixed, and no progression patients, where we can further define progression into that systemic and mixed categories. And what we saw is that they had distinct survival outcomes, even if one of them didn't quite reach statistical significance. And of course, the reset criteria is also prognostic at this stage of disease. So, summarize the results. One of the really important advantages that molecular imaging offers is the opportunity to characterize progression at the lesion level. So this is something, of course, that blood biomarkers, for example, can't do. So that gives us sort of a patient level summary of what's happening at best. It cannot tell us how individual disease sites are progressing or when they're stable. So what we did in these 2 studies is we added some important evidence of the prognostic value of 2 specific, 3 actually, response assessment frameworks at this stage of disease. And again, I should stress, they have not been validated at the biochemical recurrence stage of disease yet. So this will be the first time that they've been validated at this stage. They are prognostic for overall survival. We found that lesion level response assessment can change purely depending on the imaging biomarker you choose, right? So if you choose a different biomarker, that can change how you're assessing progression at the lesion level. And we attempted to correlate that those different biomarkers and response assessment thresholds with the important clinical endpoint of overall survival. And our results suggested that SUV mean might be the best to use if that is the only criteria that you're considering. We also found, as I showed in the previous slides, that all the other biomarkers except for volume were highly prognostic as well. So, for example, if a particular centre doesn't have access to automated delineation methodologies, then it might be impractical to calculate SUV mean for every lesion, right? And in that case, you might want to use SUV max, which is easier to implement. So, and this also adds important evidence again to that promise framework that I was talking before, which suggests the PPP and RECIP criteria as two potential response assessment frameworks that can be used for interpretation of PSMA images. I've been through the literature. The evidence supporting this up until this point was very scant. So we've added some important evidence that suggests that they are prognostic and you can use these frameworks at this stage of disease. But I should mention we want to validate this more. So this was a retrospective study. We'd like to do prospective studies as well in order to make sure our results are correct. We'd also like to implement AI-based methodologies into this. We analysed purely the nuclear medicine physician delineations in this study. And the reason we did that was because of the difficulty basically in registering, determining which lesion was matched with baseline and follow-up based on AI delineations. It would either require us to manually go through each lesion and match it up to a follow-up scan, or implement some registration techniques and do that classification automatically, which definitely can be done, and we're looking at that. So I covered a few of the limitations already just then, but as I said, relies very heavily on the delineations of a nuclear medicine physician. Of course, there is intra-observer variability that needs to be accounted for in this, so different observers are going to segment different numbers of lesions and different areas of lesions when they do agree that there's actually a lesion there. And of course, this is an extremely time-consuming process. So this is something that outside of clinical trials probably isn't going to be done in regular clinical practice, which is why we need to incorporate these sort of automated delineation methodologies into this process and assess whether they are prognostic as well. As I mentioned before, median of 2 lesions per patient. So overall, for metastatic prostate cancer, is a relatively low disease burden cohort. And the conclusions that we draw here are only relevant to this cohort. So it might be the case, for example, that if you have a patient with a disease burden such that on the image that I was showing before, really extensive disease burden, then this sort of lesion-based approach may not be appropriate, and it might be more appropriate to use, for example, change in total tumor volume between 2 scans. But we need to validate that in future studies. And yeah, so future prospective studies are what's necessary here. So I'll spend just a minute or so on future work. One of the key things I think future work should look into, in my opinion, is what's called a radiomics approach. So we extracted a few biomarkers from each of these lesions, but we really limited ourselves to the ones that are most likely to be implemented in clinical practice. So we're talking about SUV mean, maximum peak, and volume. But of course, there are many other biomarkers that we can potentially extract from these lesions. In fact, there's pretty much an infinite number of biomarkers we can extract from each lesion. These include shape-based features characterizing the shape of those lesions, texture features, first-order statistics. This would include your SUV mean, maximums, etc. And what we could sort of undertake is what's referred to as a radiomics approach, but we can then extract those features from the lesion, characterize what's going on there at potentially a more in-depth level rather than just relying on these more basic imaging features, select the most appropriate features and then correlate those with the endpoints that we're interested in. So of course, we'll be interested in patient-level endpoints like overall survival, progression-free survival is something that we'd like to look at as well in future studies. But the really exciting stuff is when we start thinking about lesion-level endpoints. So for example, can we characterize what's going on at the individual lesion level at a baseline scan such that we can predict whether this lesion is going to be difficult to treat, whether it's likely to respond or not to the therapies that we're trying to give patients. So this is where sort of future work, I think, is going to go in this space. It's going to take a lot of time. But eventually, with sufficient validation of these sort of techniques in well-designed studies, I think we can get to the stage where we can predict this at baseline. So that's it from me. Just a couple of the references that I used for the presentation there. And of course, it would be remiss of me not to acknowledge everyone who's helped me very, very significantly throughout my PhD. Those were just two of the papers I published as part of my PhD. If anyone is interested in reading more about it, you can subject yourself to my thesis if you like. I'm not sure if you want to do that, but I'm happy to provide it. So many thanks to everyone on the screen, and many thanks to everyone here for listening. Thank you. Happy to take any questions if you have any.
Just curious, how did you get the survival data? And that's the only clinical endpoint that you collected, was it? Yeah.
Yeah, from the cancer registry. Yeah, so all that data was from the cancer registry.
Yep.
But yeah,
the next question is whether we can alter that outcome, because it seems depressing that in the second paper, all you've done is taken a 6 months PET post diagnosis of biochemical failure, and you can already predict who's going to more likely to die,
well, that's
irrespective of intervention subsequent to that.
Yeah, which is, it's definitely concerning, and I think probably you're right. One of the things we like to look at is what actually happens when you change the management for these patients. Right.
It's very heterogeneous in this group.
Yeah, definitely. So, you know, as you said, the heterogeneous treatment modalities probably play a factor into this. If we had a more standardized approach, we could say, all right, you know, at this time point, the probability of survival is quite low, but what happens if you actually change the treatment to X, you know, maybe one of these drugs potentially, or a different one or whatever? Can you actually improve those outcomes? Yeah, definitely. Thank you.
When you're saying that hopefully you'll be able to do it so that from the initial scan you'll be able to predict which of the lesions may progress and stuff like that, do you think that would then ultimately change the survival rate? But
yeah,
what method of treatment you'd be using?
Yeah, I think so. The thing that I'm envisioning, right, would be, you know, you have at baseline, you characterize what's happening at the imaging level, and you have all of these other clinical features that you can put into these models as well, right? And it uses that information to predict, okay, what's the likelihood of this lesion progressing, given that you're giving the patient ADT, for example. And in that case, would it be more prudent maybe to target that particular lesion with aggressive radiotherapy techniques, for example? And in that case, would that lead to an improved survival rate? I hope so. We don't know, unfortunately, but yes, I think if you could predict which lesions are going to be unlikely to respond, then yeah, you could target them for more aggressive treatments, and that would hopefully improve the survival rates. Cool. Thanks, everyone.
Thank you.
Thank you.
Just checking. Is Jeremy the one that did all the contouring?
Yeah. He did all of it. Yeah, he did stuff. It takes so long to do it.
Good work.
Yeah. No, thank you for that.
Yeah, no, I like it.
Hey, Marty.
Hey, Alan. Yeah, good.
Yeah. Growing. Yeah.
Good. Well,